Well, welcome to the iWound Symposium on the impact of COVID-19 on wound care. Today, we're going to have a great panel discussion and talk about how it's impacting the work we're doing today. And we're going to segue into some future thoughts about not only the disease itself, but the impact on wound care long-term and frankly on healthcare long-term. So to begin, I'll be your moderator. My name is Bill Ennis. I'm professor of surgery and wound care at the University of Illinois at Chicago. I'm also the chief medical officer for Healogics, and I serve as the president for the American College of Wound Healing and Tissue Repair, which is a nonprofit organization dedicated to developing the specialty of wound care. Now, I'm joined today by a wonderful panel, and they will introduce themselves here in a second, and then we'll dive into the questions.
I am Dr. Desmond Bell. I've been a wound specialist for 20 some odd years now and have dedicated my professional career to lower extremity preservation and amputation prevention. I am also the founder and president of the Save a Leg, Save a Life Foundation, which is a nonprofit organization. And I also serve as chief medical officer for a company called Omeza, which we are a startup, and I've been involved in the product development since its inception over 10 years ago, really, for wound care and skin repair.
Hi, my name is Mike Edmonds. I'm a diabetologist working in the King's College Hospital in South London. I work in the diabetic foot clinic, a multidisciplinary diabetic foot clinic, serving primarily the sector of Southeast London, of a population of 1.8 million people.
I'm Dr. William Lee. I'm an internal medicine physician. I'm the CEO, president, and medical director of the Angiogenesis Foundation, which is a not-for-profit organization focused on the microcirculation. I've been involved with wound care for the past 25 years, as well as innovations, and I'm also actively involved with COVID-19 research and its effect on central and peripheral tissues. I'm also on the board of the American College of Wound Healing and Tissue Repair.
So thanks everybody for joining us today. And we're going to try to spend our time in two buckets. We're going to open the conference and look at really everyone's experience on the impact of COVID on wound care systems, whether it be individual practices or at a systems level. And then the second half, as we close, we want to think a little bit more to the future of wound care. What is normal going to look like? How will this change, frankly, how we practice medicine well into the future? So we're going to start with, and I'll just go around and I'll ask individuals, but how has the practice, your individual clinics, been impacted by COVID? By that, I mean, we were asked, at least in the States, we were asked to shut down outpatient services. We were told there was a difference between essential and non-essential services. There wasn't really a lot of clarity or granularity as to who defines that and who makes those types of decisions. And so cases were determined to either be kept out of the clinic for a month. People scrambled to look at telehealth options. But we personally seemed like we were left to figure out our own triage system. So let me start, Des. There's been a lot of talk about the impact of this virus in the podiatric world. A lot of talk about people sitting at home, with potentially infected diabetic foot ulcers. What are you seeing? What are you hearing from your colleagues, and what have you seen personally?
Yeah, so, my practice has, again, primarily been wound care and limb preservation for many years, and most recently I've worked out of a hospital-based wound care center, community physician. And, initially it's just been a reaction to all this. Nobody really saw this coming, obviously. So what you mentioned, Bill, we've been kind of left on our own to try and figure it out. So initially we've kept patients out of clinic. My colleagues have actually kind of taken a little time too, trying to a little self-preservation in a sense too, but really trying to protect the patients. I think the full impact is still yet to be felt as to some of the long-term things that will have happened, whether we're going to see a spike in hospitalizations for infections and that type of thing, just from that 2 to 3 week period where patients were not coming into clinic.
Mike, in the UK, did the NHS have a similar mandate? Did they speak to? You guys shut down a little bit later than us, and so the question is: were you told the same things? No outpatients, and if there are, they have to be essential. And how did you guys define that?
The NHS acted in a similar way. We had a mandate to differentiate between life and limb-threatening conditions and other diabetic foot conditions which we could treat in the community out of the clinic. So we had to preserve resources for the hospital itself. From the beginning of March, there was an avalanche of COVID patients coming into the hospital, filling up the ITU, taking over the wards. At one time we had nearly 600 COVID patients in the hospital, and only one ward which was not COVID. And one of the effects of that was to take staff. Staff were redeployed, and some of the staff from the foot clinic were redeployed. But I think the NHS acted as a whole, and the mandate coming from the NHS actually said that multidisciplinary foot clinics should continue. So we didn't have to close down completely, but we had to triage our patients so that the patients who were non-essential that come to the actual hospital clinic were treated in the community. So we've conducted an reorganization essentially, so that the more simple ulcers, the mild infections were transferred to the community. And in so doing, we created an umbrella, a safety net of care by linking up with the community podiatrists and the community nurses. So that sort of microcosm was to look after the less serious patients, but have support from the multidisciplinary clinic. And that support has come from a modified form of telehealth by telephonic support and by WhatsApp systems, which can link in with the multidisciplinary team. So we feel that we've kept the standard of care to our patients, but on the other hand, been able to reduce the number of patients coming to the clinic by about 30 to 40%.
Yeah, I just want to throw something there. I think that you just made a really interesting comment, Dr. Edmonds. And I wonder if, as we kind of look to what will become the new norm, if people like essentially the payers or the government agencies look and say, well, look, you still managed to see these patients and patients were still receiving care with a decrease in the number of visits to the outpatient clinic. So I wonder how this is, how quickly the impact on outpatient wound care centers will be noticeable, let's say, or if this is going to create a new a new shift the way our services are provided. And we saw kind of similar to what you did. We triaged as well. Initially, we condensed our outpatient wound clinic. We cut back the number of days because we were simply keeping the patients who are obviously high risk away from that environment of the hospital. Here in Jacksonville, Florida, we didn't have as many COVID cases as some of the other major metropolitan areas, fortunately. So we were able to kind of get back into it. And now the pendulum has started to swing back and we are busier. But I just think for the long term, this is going to be something noteworthy, and how it's going to have a direct impact on, will wound care centers really be the same? It sounds like, in a sense, that there's a recognition of the importance of the services that we provide. However, there may be a de-emphasis on the outpatient wound center. And now you've got these specific groups or providers, whether it's the community nurses, the podiatrists, but the danger is, will they work in silos? But it sounds like you've got the person to kind of coordinate that communication between the specialties, and I think that's critical. I've said for years, limb preservation centers, you don't necessarily have to be under one roof. You just have to have good communication within the specialties and the community.
So I want to hold on to that concept before I ask Dr. Lee a question, because the healthcare system that we're describing between Jacksonville and the UK really becomes of paramount importance, because that infrastructure wasn't created simply for COVID. It was in place and then augmented and used to a greater degree. I think it emphasizes the frailty of the US healthcare system. I think this exposed a lot of our lack of communication, lack of using community. But before we say that, people did okay. So, for example, the Healogics database, which has over 600 hospitals, we're actually going to be publishing on whether or not there was a clinical impact. I mean, we can say that we're providing this care in the community, but we have not yet been able to statistically compare that to the cadence and frequency of visits in a clinic, amputation rates, hospitalization rates, infection rates. So more to come on whether or not there is truth to that. We deployed it, but we don't know the efficacy of it. Dr. Lee, when you think about oncology and other disease states, they too had to have this triage, what's essential, what's not. I watched a webinar yesterday from Mount Sinai Hospital in New York, where a breast surgeon, the topic was COVID and breast surgery. And I thought, well, what could this possibly be? It was all about what form of breast cancer can have neoadjuvant first, what can have hormone, who can delay surgery, who can delay XRT, et cetera. What do you think we're going to learn from other disease states, as we did in wound care, of how to create this essential, non-essential? It almost seems paradoxical to even call those things essential or non-essential when you're talking about cancer.
Well, I think that the responses that the different medical centers, both academic centers and private practices, urban centers versus less urban or rural centers, are all struggling right now to come to terms with how they, in retrospect, dealt with the last 2 months. And it's true, many of the centers shut down non-essential care without a definition of non-essential. There were other groups that just triaged all, assigned certain hospitals to be COVID centers and other hospitals to be non-COVID centers for elective or more elective surgeries, and then deployed their staff accordingly. I don't think that that's a sustainable model for any healthcare system. I think that among the weaknesses that have been revealed, I think across the board in every country, is the lack of a centralized plan to deal with a sudden need to react acutely while still managing those chronic situations. In oncology, obviously, you would never in peacetime tell people not to forego their chemotherapy or their surgical tumor removal. But in this particular case, without sort of centralized guidance, it was pretty much every ship performed as best that they could. And don't forget, patients are also an important part of the equation. If they choose not to show up or they choose not to follow up, then suddenly you've actually broken the system from the patient side as well. And so this other thing that we've learned, I think, is the need to be able to have really sound communication to everyone about what they should do based on the acuity of their situation and who they actually contact. So I think one thing we're going to learn from that other specialties are going to teach us in wound care is the need to actually have a protocol for normal management, sort of acute response management, and then how to triage those patients according to need, but also where do you actually send them and what's the chain of communication that's required. This is true for any specialty.
It's true. The telemedicine explosion was really fueled by this pandemic. but probably should have been happening a long time ago anyway and focused into. So if each of you could just take a second on, have you utilized any form of telemed and your initial reactions to it? So Des, why don't you start?
I guess I've been a proponent of telemedicine for years because I saw the value as smartphones and the technology emerged. It's like, why wouldn't you use a phone to communicate with your patient or vice versa? And for years, I've been telling my patients, look, if you develop a problem, please, between visits, I should say, please do not wait until your next visit. Send me a photo, keep me apprised of what's going on, and then I can guide you through this. And this is one of the silver linings, I think, of this COVID issue, is that something that we've needed for a long time has been pushed to the front of the line, and it's going to really have invaluable reaching.
Dr. Lee, any negative implications in your mind about the patient-physician relationship? Millennials would rather, 60 to 70% would rather see a GP or an urgent care through an app and have no interest in really establishing that type of relationship. You see the downside to some of this?
Yeah, I mean, I think that, first of all, there's a lot of heterogeneity in terms of the comfort level of physicians and patients alike with technology. And not everybody, some of our most needy patient populations don't necessarily have access to the kind of technologies that might be required to do reliable telemedicine. I think that's sort of one of the issues about the disparities of technology. That's one issue. The second issue, I think, has to do with privacy. Many of these telemedicine type of consults occur in whatever space we're in, and that might be appropriate in an emergency. But actually, as we get into sort of the ebbs or the nadirs of these anticipated COVID kind of surges in the future, where is this going to take place? In a car parking lot? What about the clinician? And then the other issue is actually control of time. If you schedule a televisit, I think that's appropriate, but it becomes really easy without some sort of protocol or control to just, try to reach out to your provider at any time, which I think patients might like, but clinicians might not be able to handle that as well. And then finally is documentation, being able to do appropriate care on the fly using telemedicine, which is some of what it has been on. Again, we need a structured approach to this, is how do you appropriately document it? And then how do you actually then share that documentation with other providers? We already had pre-COVID enough difficulty, having the different clinics communicate with each other across disciplines, the cardiologist with the wound clinic, with the renal specialist. Now, if all these things are being done by telemedicine, how do we actually communicate that appropriately to the other specialists managing our complex patients? I think those are challenges, not so much downsides, but they're going to have to be contended with. And then even, what we're learning with, typical Zoom calls is sometimes you wind up actually having connection difficulties. And, with telemedicine, one of the things that we need to recognize is we're really dependent upon a functioning internet. If that were to go down at any point in time, we don't have an alternative system to actually go to. So I would say one learning from COVID is that, just how reliant and grateful we are that the internet exists. But also, by the same token, another kind of downside is how vulnerable we are without an alternative internet.
Yeah, think about stepping inside the hospital and getting the iPhone alert that the EMR is temporarily down. It becomes anarchy. People start running around, just spinning. I spent time in my clinic recently when that happened, reintroducing people to yellow pads and pens. I explained that things could be written down, patients could actually be spoken to, and they could have their history given to them rather than looking for it in Cerner or Epic. It was an interesting experiment. But yeah, so what do we do with triage if there's a simultaneous either attack problem or just infrastructure breakdown, grid kind of breakdown? I agree. Anything shock you, Professor Edmonds, about this that just you didn't see coming outside of the obvious?
You know, we've seen coming into us patients who were thought to have diabetic foot infections, and they had COVID because they were really very ill from the septic aspects. And then we've also seen patients the reverse, you know, patients who've had a massive foot infections that were thought to be COVID and you know, the conventional foot flu, and it's still coming to great problems with their foot infection. So the interrelationship between COVID and diabetes has really been a very dramatic one.
Dr. Lee, taking from that last statement, you've had some interesting thoughts, I know, and working on a couple of papers right now about that very concept, right? So clearly there's a subgroup of individuals who, we wrote a paper from the, as you know, from the American College, physician paper saying that the people that are vulnerable to COVID are in fact the same people that are in our wound care clinics, right? So we knew right away that there was going to be this vulnerability piece. But if you could speak just for a couple of minutes on the interconnection. Professor Edmonds talked about diabetes, but thromboinflammation and other aspects of this disorder seem to potentially have much greater far-reaching impacts on the systemic disorders. And so the wound is nothing but an end manifestation of some systemic disorder. And so we're going to maybe be seeing wounds in a different way or presenting in a different way. What are you thinking about that? And what have you learned in your recent research?
Yeah, so as somebody who specializes in the microcirculation, one of the things that I did was pull together my research team, and we began actually looking at tissues of people who actually had succumbed to COVID-19 and trying to understand what's actually happening at the pathophysiological level, at the ultrastructural level, and really interested in looking at the microcirculation. So we found a couple of very interesting things that are about to be published in the coming days. We found that the COVID-19, although it's a respiratory virus related more to the cold than to the flu, which is an influenza virus, that the coronavirus, which is a cold virus, gets into the lungs and it makes a beeline. These virus particles make a beeline to vascular endothelial cells at the alveolar capillary network. So really in the gas exchange network, that's where these viruses go in. And so if you take a look at the electron micrographs of these pulmonary vessels right by where the virus is, they look like they are filled with gumballs, you know, the old gumball machine. So you have blood vessels lined with endothelium, which is already problematic in diseases like diabetes and, you know, in aging with atherosclerosis. And now you actually pack them with viral particles, viruses. And what we've also discovered is these viruses actually upregulate the receptor, indeed the ACE2 receptor, that they actually come into many-fold. And so this is really a angiocentric or a microvascular disease as much as a respiratory disease. And that then brings us straight over to the wound. Because although we've looked at thromboembolic phenomena in the lung, which is what we're going to be publishing on, we're also seeing it in the brain. We're also seeing it in sort of the larger vessels, whether it's a cerebral clot or whether it's a pulmonary embolus or a DVT. But you also saw this phenomenon now described called COVID toe, you know, the chilblain phenomenon. And no doubt we're going to be finding other microvascular involvement of COVID damaging endothelium in areas which then set up for an immunological clearance of the virus in that endothelium, which will then further damage the microvessel. And so what we are beginning to realize is this is not the classic cytokine storm where, although it may look like that when a patient is on a ventilator, in reality, you're talking about lots of piecemeal microvascular thrombosis with an immunological clearance of the virus in those areas, further damaging, further clotting. And if this is happening in the lower extremity in a diabetic patient or an elderly patient with an ischemic ulcer or propensity to form one or a diabetic ulcer, and think about an ulcer that's already open that needs to heal. You need good, healthy endothelium or best possible endothelium to granulate in. Now imagine there's viral involvement of that endothelium with microthrombosis in wounds that need to granulate, I think we haven't even begun seeing some of the potential downstream problems from COVID-19 infection in our diabetic population. I think it's something that since we know this might occur, we as a wound healing community, as clinicians, should unite and start to gather that data so we can quickly get our arms around it in the same way the infectious disease docs have actually tried to gather data from the respiratory side. And secondly, we should mobilize the research teams to really be able to take some of this tissue and look at it. So, for example, if there is an amputation, whether it's an entire, like a BK or AKA, or whether it's a ray amputation, we should take a look at that tissue and begin diving down to see if we can find any COVID correlates that may actually help us. Now, the other thing is that the American College of Cardiology just published yesterday improved clinical outcomes from ventilated patients who actually have anticoagulant therapy.
Yes.
So should we, as a wound care community, suddenly start to think in our patients who have chronic wounds or might have chronic wounds, some form of adaptive anticoagulant treatment to be able to mitigate either the formation of wounds, to improve healing of wounds, or prevent recidivism? These are all outstanding questions that I think we can start to think about now.
So I'm going to segue the conversation to the future for the second half of that, because it's a perfect opportunity. Let's look back at the meta-analysis on venous ulcers. Scant, rare papers that get talked about from the podium but don't really get promoted, that if you were on sub-Q heparin, your skin graft take rate was higher. Your venous ulcer healing rate was higher, whether it was aspirin, Pathophysiology, right? There have been rheologic agents that have been looked at over many years in the wound care space. As these folks recover, so we have the unfortunates that pass away, but a much greater number of people are going to recover. And the question I have for you is, number one, not only how do we ramp back up, but and I'll start. Well, Des, you were about to say something, so I'll go there. Do we think there's going to be a long-term sequela change at the endothelial level in the diabetic? Have we created a chronic disease? We never got a vaccine or a cure for HIV either, right? We just manage it as a chronic disease. Are we looking at the same scenario?
Yeah. So, Bill, as Will was speaking, to answer the earlier question you had of me, it's like the thing that surprised me the most, I guess, after having a chance to really think about this, was the impact on the otherwise younger, healthy patients who have been succumbing. And so with that, I'm wondering, listening to Will speak about this and the downstream effects, are we going to see, let's say, the younger ones who survived, are we going to start to see some wounds coming in on these previously healthy patients who were exposed or had CV-19 and now have chronic ulceration or have developed some type of wound as a result? So I think we're going to need to really keep our eye out on that and start looking for data on that too. I think that's going to be really important.
Professor Edmonds?
Well, going forward, one aspect I think is very good control of the diabetes. I know in a way that is obviously to say, but metabolic inflammation, I think, is driving some of this condition. And we know from the previous SARS work that there's this interrelationship between metabolic inflammation and the immunological responses. So certainly in this present pandemic, very good control of the diabetes is important. And I think following the issue of the microvascular, which we've just heard about, I mean, what can we do from a diabetic point of view to keep the, as it were, background microvascular abnormalities at bay? And that's very good control.
Yes. So as we hear the back and forth in the literature and from the scientific experts about vaccine, whether or not that occurs, how do you guys think about the new norm for the wound care? So Des, you talked about maybe a reduction in overall volume to the clinic. Professor Edmonds, you mentioned you've already been able to triage the community, some of the easier cases. There's a backlog of folks who have a whole bunch of stuff going on. In the US, there was a reported 41% reduction in ED visits for coronary disease, MIs, and there's a marked reduction in strokes. So there's a bunch of theories as to why that is. Some of it's, they're staying at home, there's underreported, and there's some overutilization of treatments, right? So it's really going to be hard to tease that out. But assuming that we're a year and a half away from any of that, maybe that reduction in volume is necessary anyway. We have to have, I just spent the other day mapping out every 6 feet with little tape on the clinic, and I went from having a clinic that could house 50 people to about 16. How am I going to do that? Are we going to be Saturday, Sunday clinics, night clinics? Des, what's your thought about throughput, efficiency, productivity? Who's going to staff those things for all those additional hours? What's your thought?
Yeah. Well, we providers, we're kind of the rate limiting step of all this too. To me, I think for years, one of the weak links of the wound care model is we only have so many really, top-notch providers in a sense, or people who are truly certified and look at wound care as a full-time specialty. So, it's going to shake itself out. I think that really the old model that we've seen is going to be, it's not going to completely go away, but there's going to be some major adjustment to it. Like we've used the word triage today. Patients are still going to need their debridements. They're still going to need to be offloaded. Those type of patients will have to be seen. But I think some of the other ones that we can coordinate with home health or outpatient services of another form that maybe we haven't even figured out yet will become more the norm. And obviously, again, tying it in with some of the telemedicine, I think that's all going to happen. But I really, again, I look back to the payers now too. I think they're going to take notice on this and say, well, wait, you guys were providing your services. We didn't have as many visits to the wound center. And if we can continue along that model, we're gonna go for that. So I think there's going to be this, again, de-emphasizing on the services provided or the frequency that you'll be able to go to an outpatient wound center. I kind of see that coming.
Professor Edmonds, do you think there'll be an increase in I think your country shows community modeling way better than we do here in the States. Do you think that's going to be emphasized even more? And if so, what type of care providers do you think will be deployed into that community to obtain this better glucose control, better lifestyle adjustments that you refer to? Who's going to be able to do that?
There already was a trend to increase resources in the community way before the National Health Service plan was to increase resources. And I think this pandemic will accelerate that. But you can't stop ischemia progressing in diabetes, particularly the critical ischemia. When critical ischemia is there, you've got 2 or 3 weeks to get things sorted out. And we've noticed that we have been dependent on angioplasty. Because of the hospital situation, our vascular surgeons have not been allowed to do distal bypasses up till now. Only if they are classed as emergency ones. So we've been trying to go by with angioplasties, but over the time we are seeing that we don't solve the problem entirely with angioplasties. You need to get pulsatile blood flow back to the foot. And that is with the distal bypasses. And I'm pleased to say now, with the cases falling down at King's, next week, our vascular surgeons are able to start with the semi-urgent distal bypasses.
Yeah, our elective cases open on the 11th. And to your point about, we just sat the other day, just yesterday in clinic, going over an angiogram, and I commented to my colleague how we were I mean, we ended up with a decision on a below knee amputation based on that clinical exam and that angiogram. But it really was influenced by the fact that the target vessel, even though there was a small target vessel, was going to be such a morbid procedure and a difficult one in this time frame to keep that patient exposed. I mean, it was fascinating to me how we both walked away from the angio and said, that's not a decision we probably would have made, 8 weeks ago. And I mean, we are very heavy into the distal reconstruction at my facility. So it's really impacted us the way we're staring at these. So I'm really going to be interested in outcomes measures that we see with Medicare claims data and hospital data on amputation rates. Des, you save a life, save a limb. And I mean, here I was, just like you, always wanting to, but we all agreed that we're going to have to do a BK and get out on this one. And how many others are struggling with those conversations and those decisions? It's going to be very difficult, and the data will, I guess, let us know how it all played out.
Yeah, you play the hand you're dealt, basically. And that's how we've always done it.
Just to say, I've heard it said we're in the middle of 3 epidemics of old age, renal failure, and diabetes, and now a pandemic has come along and hit us.
So as a wound care community, as we get close towards the end of this, I will say, and I want you all to comment on how you think this might change our stance. Various organizations got together and wrote a letter at the end of March to Medicare when the essential, non-essential commentary started to be made that wound care is in fact an essential service. And Medicare and the governments of all the countries around the world were inundated with, every disease state is basically sending a letter and saying that, they're an essential service. Over time, Medicare did respond quite rapidly and with a lot of relaxation of regulations here that have allowed, number one, wound clinics to stay open, like Professor Edmonds' clinic. The NHS seemed to also understand the importance of that. These relaxations of rules have led to a broad adoption of telemedicine, broad adoption of getting durable medical out to patients' homes without the need for face-to-face visits and signature, et cetera. But one of the issues, the most recent 2 nights ago, Medicare was still struggling with, well, how is a telemedicine wound care visit going to happen? And really, when I worked with the group that was designing the response, their thought is still a bandage is taken off and a bandage is put on. And, that is such an insignificant component of what we all do and what the patient requires. Maybe this is a battle cry for wound care as a specialty and as an organization, as a constructed organization. The cardiologists had a good response to this. The American College of Surgeons had a good response to this. Oncology has had a response to this. But wound care actually now 3 nights in a row on the Medicare callouts at 5 p.m., the word wound care was actually mentioned by CMS staff. So we'll go around and just say, do you guys think that we're in a point where we're not going to have public meetings and some of these symposia? We just lost the ability to go to the Charing Cross meeting, Professor Edmonds, at your country, and these are wonderful opportunities. So I guess I'm going to ask you guys to talk about the balance of that. I think we have momentum as a specialty right now. Do you think we'll be able to continue that with the lack of exposure that we get from our normal venues of meetings face to face? And is Zoom going to be good enough for us to get our message out? I'll start with Desmond.
I think we will see hybrid type meetings. Obviously, when we go to our conferences, there's so much value in the sidebar conversations that occur, the ability to, visit exhibit halls and look for technology and that type of thing. The didactic can be probably addressed through Zoom conferences, but I think it's going to be a while, and it's going to be some reinvention of all this. But I think we always figure it out. So I think some of the positive fallout from all this will be that, yeah, there is a recognition of the importance of what we do. And to your point too, it's not simply just changing a dressing. That's the least important part of the equation, which people are finally maybe starting to realize that. So I just think that, you know, we are just great. We're all problem solvers, and we just have to we will start figuring things out. It's amazing what's happened over the past month in some of the little, I don't want to say opportunistic type things that have happened, but now you've got, you know, these PPE industries have popped up. And so, you know, as far as where we will go, it's hard to say how it's all going to shake out, but I think the wheels are in motion now, and we're going to make progress as a wound care community.
Professor Edmonds?
Well, treating the diabetic foot ulcer is really very much a holistic pursuit. It's treating the diabetic patient, it's treating the vascular aspects, the infective aspects, treating the neuropathy by getting really good control and getting good control of the renal problems. So it's just not addressing. We've got the three epidemics, as I say, and that's going to drive us. We can't avoid that. Those three epidemics of elderly people with renal disease and diabetes are going to drive the need to get as good care as possible for these patients. And I think you might say that the patient with the less severe ulcer has actually had improved care during this pandemic. You know, they're being treated in the community, they're being treated at home, they're being followed, they can take pictures, they can get in touch with us very, very quickly. You know, there's nothing worse than having a chronic illness and then having a major problem in getting help, medical help, when you've got to go through one secretary help and through layers of bureaucracy. So I think this pandemic has improved care in those patients. And I think that equilibrium and that dynamism will go on into the future. So I'm optimistic, actually.
Dr. Lee, some final thoughts?
I think it's really clear that the era of make it up yourself wound care for in the patient's interest is over. I think one thing this pandemic has done is essentially level the playing field for everyone, where regardless of what practice you're in, what center you're part of, what society you belong to, we've all been kind of reduced to ground zero. And so I think there's an opportunity, thinking ahead, to develop a set of best practices, really on the international level, from my perspective, of all the people that actually want to contribute to looking at how do we actually prevent, treat, and help to manage long-term people who are vulnerable in the wound care setting, without a lot of fancy equipment, without a lot of conferences, without exhibit halls and all that other stuff, the clouds that we've been surrounded by, and just have some clarity. How do we do this properly? How do we do this de minimis, which is what we may wind up with during the dance, as Professor Edmonds was talking about. And I think if we could actually get some sort of international consensus on what that would be in the setting of what we're learning with COVID, then we would actually have an opportunity to reboot all the competitiveness that goes on and pettiness that goes on with wound care, and at least have a new starting point. The opportunity, I think, of having this gigantic pause in all of our lives. I call this the cough that brought a civilization down to its knees. As we get up on our feet, we do have some clarity on what it is that we actually need to do. And I think one of the things that Professor Edmonds brought up that I think I agree with, we've actually learned how to adapt to take care of people in the community without a lot of stuff. And we can kind of get leaders to converge on a consensus of what that would look like. And then we can make a layer cake on top of that all the way building back to those halcyon days of, being surrounded by all kinds of gadgets and toys. I think that there's a new opportunity for leadership to harmonize the practices that would allow wound care to become more recognized in its own right as a specialty.
Well, I want to take the opportunity to thank Drs. Bell and Lee and Professor Edmonds for joining us today on this webinar. I think we ended on a very positive note, that there's a lot of things that we have learned. There's a lot of things that we need to still do. We need to be prepared for the future. As Dr. Lee mentioned, we don't know what reality and future state that's going to look like. Every day there's a new modeling output. But we really have to just wake up every day and see our patients and try to make this thing as good as we can. So from the iWounds group, I want to thank you all for joining in and look for additional information and messaging and education from us in the future. Thank you.
Thank you.
Thank you.